I'm Daniel Levine, and this is the Bio Report. The National Comprehensive Cancer Network in October will release a new tool designed to help doctors understand the value of different cancer therapies by taking into account the cost of treatments. The effort from the influential group follows similar initiatives by Sloan Kettering Cancer Center and the American Society of Clinical Oncology. We spoke to Bob Carlson, CEO of the National Comprehensive Cancer Network, about the rising cost of cancer care, the new tool, and what impact it will likely have on drug pricing in the future. Bob, thanks for joining us.
Pleasure to be with you.
The National Comprehensive Cancer Network, your alliance of 26 cancer centers, is preparing to make available a tool that will help doctors determine the cost and benefits of cancer therapies. Before we discuss the tool itself, perhaps we can begin with the problem it's trying to address. We've had great advances in cancer care. It's been an area of innovation, but what's happened to the cost of care?
Well, the costs of cancer care are rapidly increasing, and it's across the board. But one of the major sources of the increase in cancer care costs relates to the systemic therapies, the drugs and biologic agents that are used to fight cancer.
Well, what's driven the rising prices of cancer drugs, and have those increases been justified?
Well, I'm not someone who sets drug prices, and so I can't tell you exactly what has driven those increases in expense. I think some of it relates to smaller populations of patients being appropriate for specific agents. Some of it relates to the expenses of developing drugs and showing that they have benefit. And I think that part of the expense of drugs relates to what many of us would interpret as relatively high profit margins among the pharmaceutical industry.
How big a shift would you say we're seeing in doctors starting to weigh the cost of therapies and making decisions about treatment options?
I think we're seeing a dramatic shift in awareness among physicians, especially oncologists and hematologists, about the expense of agents. Many physicians who have been silent on this issue in the past are now stepping up to the plate and talking publicly about the difficulties of expensive agents. And some of that comes from hematologists and oncologists having patients who have had to declare bankruptcy because of expenses of care. Patients who decline therapy because they don't want to bankrupt their families, or they don't think that the benefits of a specific therapy over a less expensive alternative are worth it.
Cancer drugs represent a big business. It's a $100 billion business globally. The pharmaceutical industry has been defensive about its pricing and not surprisingly protective of it. Have you heard from the industry at all as you get ready to implement your tool?
We have. We've heard from multiple of our stakeholders, including industry. And industry does have concerns about us including cost of therapy as one of our measures in our guidelines.
What kinds of things are they expressing to you?
Many of them are quite legitimate concerns, and one is that we are using an estimate of cost provided by experts from our guidelines panels. It's not an economic calculation or an actuary calculation of what the actual dollar cost would be, and they have concerns about that. And also importantly, with the payer environment in the United States, with multiple different payers and with multiple different contracts for insurance programs within each of those individual payers, it's often very, very difficult to come up with what the costs would be to different stakeholders. So, for instance, there's a cost of care to society that would include loss of opportunity for work and that sort of thing, potentially from a treatment. There's a cost to the insurance company for payment. And then there is, of course, the cost that the patient would be expected to pay, which is typically in a patient in the United States with an insurance program would be a relatively small fraction of the overall payment that a payer would typically make.
So as you go through this process of implementing the tool, is there some type of comment period you're going through where you're taking into account various feedback from stakeholders?
So the NCCN has a process. Our guidelines are updated on an ongoing, essentially continuous basis. And so we don't, as an organization, have a specific month or 2 months or whatever, sort of a comment period as we develop our guidelines and recommendations. Rather, we really have a continuous ongoing comment period where we continually interact with our stakeholder groups. We continually meet with them. We continually accept input from our multiple different stakeholder groups. And those inputs are then considered by both the headquarters group as well as by the individual guidelines panel. So anyone, literally anyone, can go to our website and can submit a request for a modification in any of our guidelines or make a comment about any of our guidelines. And at least as those comments and requests relate to the drugs and biologic agents, 100% of those comments are made publicly available on our website. And when a panel reviews those comments and makes a determination based upon those comments, the panel's deliberations, the rationale for making whatever decision they made, and whether or not the guideline was modified and how it was modified are also publicly reported and available. So we really have a continuous feedback process and participatory process from essentially all of our major stakeholder groups.
A number of other groups have sought to develop tools to take into account the cost effectiveness of cancer therapies. Sloan Kettering notably put this debate front and center in the case of the cancer drug Zaltrap a few years ago. They have since developed a tool. ASCO has been working on a tool to help doctors determine the cost effectiveness of therapies. How will your tool work, in any sense how it might differ from these other efforts?
So, first of all, our tool is what the NCCN's core product and service is a family of clinical practice guidelines that are developed by 49 different guidelines panels. And these clinical practice guidelines outline, based upon evidence when high-level evidence is available, and based upon lower-level evidence when high-level evidence isn't available, what the various options of treatment of cancer are. And our guidelines differ from almost all others in that they span the continuum of care. So they include risk assessment for the major cancers, screening, diagnosis, early therapy of early stage disease, therapy of late stage disease, survivorship course, and if patients approach the end of life related to cancer, palliative care and end of life care. Across that spectrum, there are multiple different decision points, and our guidelines panels establish what we call the category of evidence with each of those decision points. And what that means is that a Category 1 recommendation is based upon high-level evidence with uniform consensus of our expert panelists. A 2A recommendation is based upon lower-level evidence, but uniform consensus the recommendation is correct. 2B are those situations based upon lower-level evidence where there's less uniform consensus among our panelists that the recommendation is correct. And then Category 3, where there is major disagreement among the panelists about whether the recommendation is appropriate. And each of our guidelines has that designation for each of the recommendations. What we have heard from numerous stakeholders, though, is that sort of granularity of the rationale for a recommendation is really not adequate. And they have requested that we annotate our guidelines to provide additional information about the rationale for a recommendation. In terms of doing that, we have developed a program that we call our evidence blocks that really look at 5 different measures that we think are important in each of the recommendations. The first is a measure of efficacy. How effective is the specific intervention that's being recommended in controlling the disease? The second is that of safety. How safe is the intervention? What kind of side effects are associated with the intervention? The third is the quality and the quantity of scientific evidence that supports the recommendation. The fourth is the consistency of that evidence. Does the evidence consistently come up with the same answer, same recommendation, or is there inconsistency among the studies that are available? And then the fifth measure is that of affordability, that of cost of the therapy. And each of those 5 measures is scored on a scale of 1 to 5. And then those 5 measures on the scale of 1 to 5 are then displayed graphically in what looks like a 5 by 5 table that we call our evidence block. And we've done it in a graphical form because there's a lot of evidence to display at once and to process. And we have found that if we display the evidence graphically, that the users can much more efficiently scan multiple different options and see how the various options relate one to another. Our tool is different than some of the others in that we don't have an equation where we come up with a numerical recommendation that sort of is a one number fits all patients. Rather, we provide the individual measures that allow physicians and most importantly, empowers patients to utilize their own value systems and how they weigh those different considerations, effectiveness versus safety, for instance, or how they weigh cost in the equation. So we try to provide information to the users of the guidelines so that they can make their own value judgments based upon their own value systems and scales in terms of how they would rank or rate the different options of therapy.
In putting together the evidence blocks, are you relying on clinical trials data or real-world data?
It's actually both. We use clinical trials data, especially if the clinical trials are high quality and randomized, and if the clinical trials apply to the patient population that's being discussed and the appropriate clinical context. The reality is that only about 6% of the recommendations or the treatment decisions that a medical oncologist, hematologist are required to make in everyday practice are based upon high-level evidence. So if we limited ourselves only to those situations where high-level evidence is available, we would not be able to provide much assistance to providers or patients as they go through the continuum of care. So in those situations where there isn't high-level evidence, we depend upon lower-level evidence. And in some circumstances, that's the only evidence that's available is clinical experience. Our panels are populated by people who are recognized experts within the specific disease and who see that sort of patient and that sort of disease all of the time in their daily life. And that allows us to make recommendations based upon actual clinical experience in those circumstances where there isn't good evidence available.
I mentioned the National Comprehensive Cancer Network is an alliance of 26 cancer centers, but I don't think that really conveys its influence. Can you give some sense of the number of doctors that turn to your guidelines and how widely you expect your tool to be used?
So the NCCN is, as you mentioned, an alliance of 26 major academic cancer centers in the U.S. All of them are currently designated, NCI-designated cancer centers. We provide access to our guidelines free of cost from our website. We have almost 7 million downloads of our guidelines from our website on an annual basis. We have about 600,000 registered users on our website. About half of those users are from the United States. About half are outside the United States. So our guidelines are heavily accessed. They're heavily used. Our guidelines are used by multiple payers to make coverage decisions within the field of oncology. So our drugs and biologics recommendations are, for instance, used by the Centers for Medicare Services in making coverage decisions. United Healthcare utilizes our guidelines in making coverage decisions, and most other payers or pathway systems use our guidelines for coverage decisions either directly or indirectly. We also have patient versions of our guidelines, selected of our guidelines that are our professional guidelines translated into everyday English for patients. And those are also quite popular and are downloaded very, very frequently and can be downloaded free of cost from our website as well. So our guidelines are arguably the most widely used guidelines in medicine in the world. And we're very proud of that. And the usage continues to increase with time. So we think that the guidelines that are populated with these evidence blocks will be widely available and will very, very likely be extremely widely used by healthcare providers and patients within the area of cancer.
Part of what's driving this effort is to use evidence to make better decisions about care and to give patient therapies that are most likely to provide them benefit. Part of this is also to contain the cost of cancer therapies. We talked a bit about the drivers of cost earlier in this conversation, but does your solution suggest, what does your solution suggest in terms of cost drivers? Is it that we haven't paid enough attention to cost?
Well, I think that the first effort and first step in starting to manage cost is to have some transparency so that we actually know what we're paying for and about how much we're paying for that benefit or for that service. And so this really is an effort to have some transparency. It's really interesting. There is no new information in a real sense that's contained within the evidence block as it relates to affordability. The payers know what they're paying for a given clinical circumstance that their patients are within. The pharmaceutical industry knows extraordinarily well what they are being paid for a specific agent and what their profit margin looks like and so forth. That's their fundamental business. So they know those things very, very well. And to some extent, physicians understand what their patients are actually paying or what the services that they're prescribing and so forth. They have a sense of what those costs are. The people that are really out of the loop in terms of this are the patients. Most patients feel like when they're deciding how to make decisions in cancer care, it's like going to a grocery store with no price tags on anything, or a restaurant that has no prices on the menu. So they might have a very, very vague or general sense, but they really don't know what the expenses of their treatment decisions really are. So we're trying to add transparency to that, and it's a very global transparency. On a scale of 1 to 5, it's not a dollar amount that we'll be associating with any of these therapies. Is this therapy an inexpensive therapy, or is this therapy extremely expensive therapy? So it's an effort to add transparency to get those conversations started, and so patients who are cost sensitive can help to identify those therapies that are likely to be an issue for them. And of course, patients, because it's not an equation, we're just providing measures. If a patient is in a circumstance where cost is not important to them, either because they themselves have substantial personal resources or because they know that their payer is going to cover everything at a very high level, then they can choose to ignore cost in their own value equation, if you will. But it's transparency and empowering patients with information that are the driving force behind these evidence blocks.
So as you look at your own efforts and the efforts of others doing similar things, what do you expect the various impacts are going to be on drug pricing?
My expectation is that the impact will either be no impact or with time a decrease in drug costs as patients and society becomes better aware of what the real costs of providing medical care are. I would be very surprised if providing cost transparency drives the cost of care up. I guess it could, but that would be my least expected outcome.
Bob Carlson, CEO of the National Comprehensive Cancer Network. Bob, thanks so much for your time today.
Thank you, Daniel.
Thanks for listening. The Bio Report is a production of the Levine Media Group. To automatically download this podcast each week, subscribe to our RSS feed or through iTunes or other podcast manager. To join our mailing list, go to levinemediagroup.com. We'd love to hear from you. If you want to drop us a line or are interested in sponsoring this podcast, send an email to danny@levinemediagroup.com. Special thanks to Jonah Levine, who composed our theme music, and the Jonah Levine Collective, which performs it.